Okay, so you guys who have questions, we're going to try to get through this, and we will ask various members of the panels, depending on what the question's about. So I think the first one is a couple people asked this, and this is for Dr. Dillon. How does your oncologist decide between prescribing sandostatin versus lanreotide?
Great question. There's not much between them, is my sense. There certainly are some people who I put on one medication and they have side effects, and I switch them to the other medication and they seem to prefer it. There are differences between sandostatin and lanreotide in terms of perhaps how long they last. Lanreotide may last a little longer. If you trace the blood levels of sandostatin or lanreotide in the bloodstream, there's more variability in the blood level with sandostatin than lanreotide, but whether this makes any difference to anything is entirely unclear. There are people. Sandostatin is an intramuscular medication. Lanreotide is a subcutaneous medication. I think people who are super thin and have very little fat on their butt possibly would do better with sandostatin, getting it into the muscle rather than lanreotide. Again, does that make a difference to what these drugs are supposed to do? Unclear. So there's not much between them. Sometimes the insurance company just makes the decision for us. The other thing, I start people at FDA-approved doses of sandostatin. I start at 20 milligrams, but then 30 milligrams. But if I want a dose increase, that means 2 injections. So I have a discussion with people. Do they want 2 injections of the sandostatin or 1 injection of what's the equivalent of a larger amount of the lanreotide? So sometimes that's a time to make a decision between them.
All right, thank you so much. Dr. Maluccio, somebody asked, why do you need vaccinations when preparing for splenectomy?
So probably less relevant in the U.S. versus other countries where things like meningitis are more common. There are 2 types of organisms, encapsulated organisms, that the spleen is responsible for helping protect us against. And so for the most part, the spleen has very little contribution to our immune function in adults. So we worry a lot more about splenectomies in young kids, but that the vaccines are predominantly to help protect against things that are really quite preventable, but not particularly common in the U.S.
Okay. Well, Dr. White, one person asked, in liver embolizations, do the beads that are injected eventually dissolve on their own? And does embolization block the blood supply to healthy liver cells along with the cancer cells?
All right, that's a great question. So yes, those explanted livers were what you were saying, tumors, so they will stay forever. We have degradable beads. They're not available in the United States just yet for tumor embolization, but we certainly they're working on it. But those beads will be there forever, and many of the beads are made out of many different things. They will stay there forever. Yes, they block off the blood supply to normal, to everything, right? So we block those things off. They usually go pretty distal, and where the beads go is where the blood supply is. But the beauty is that despite the fact that we have the portal vein coming in, the hepatic arteries are pretty smart, and you get redistribution of blood. So if I block off one artery, as soon as I close my eyes and open my eyes again, the liver has figured out a different way to get blood supply to that region of liver. So yes, I block off blood supplies, but the liver is so smart it finds other ways. So there's redistribution of blood almost immediately on table, which is a challenge for treating tumors also. But
Thank you. Dr. Dillon, the question has come up about whether SSRIs, those are serotonin reuptake inhibitors used for depression, how do they affect carcinoid syndrome?
Thank you for reminding me about that. I forgot to mention that because it's a question that comes up a lot. Serotonin is a very important chemical. It's a very important chemical for mood. Most antidepressant medications are SSRIs, as mentioned, and SSRIs increase the serotonin in the brain. However, there's a blood-brain barrier, so the serotonin that's made from one nerve and transmits to the other nerve in the brain doesn't cross out into the body, and the serotonin that's made in the body from neuroendocrine tumors doesn't cross into the brain. It's the Las Vegas rule. What stays in Vegas, what's done in Vegas stays in Vegas. SSRIs then do not have a significant impact on symptomatology. We do find that SSRIs, there are some early case reports that were concerned that SSRIs would cause carcinoid crisis, but that really has not been borne out.
Okay. Another question came up, and this is for Dr. Maluccio and maybe Dr. White. When do you consider liver transplantation in patients with lots of liver mets?
So I can answer that. I got into neuroendocrine actually in the field of transplant, where people would be sent to us in Indiana with either the consequences of the disease or the consequences of the treatment over what could be decades of the disease. So what I think used to be debatable, and I can remember when I was just getting into neuroendocrine, and there was a lot of controversy within even the neuroendocrine community on whether or not that was a good thing to do. So I think that the Steve Jobs and the fact that he ultimately died after having a liver transplant for neuroendocrine, I think confused it. Obviously, we don't even know anything about Steve Jobs' case to know how that would have fit in with our current guidelines. There are current guidelines. So there are organ allocation guidelines, and there are legitimate types of cases where I believe that there is a clear survival advantage to single organ or multivisceral organ transplant for metastatic neuroendocrine. And they tend to be in low grade. It used to be, so the Europeans allow it to go up to a 20% Ki-67. The US, we keep it into a 10% or less. All of the measurable disease should be removed with either the single organ or multivisceral approach. And I think that we are leaning a lot towards single organ, even in cases where there is a moderate risk, like in PANC, moderate risk of additional tumors forming within the primary organ, because the liver is such a really well tolerated liver transplant. So the cases where we have used it sort of in a proactive way has been that there are cases where you have the miliary disease in the liver that Dr. White can comment on the difficulties of managing, 1,000 small tumors versus just a nice big one that has a target. I think that is where I think inevitably we will start to struggle with too much toxicity to the background liver, and so we've shied away from doing embolization. Then we use the analogs, and then we would have a low threshold in a young person for choosing liver transplant. Now, usually it's going to be a disease interval that has at least been followed for at least a year, and it's often, if you were to look at the average that I want to say it was a disease interval of around, on average, 3 years in the cases where we had transplanted them. If you want to.
Yeah, I think we get involved in, if you're ultimately, we think you're going to be a liver transplant, we sort of do this bridge to transplant, is we're just trying to keep the disease sort of settled down. And then we look at tumor biology, right? So you have to be disease sort of stable or not progressing rapidly and not having disease breaking out and going other places. And so my job in those settings is to keep the liver functioning, always number one, but two, can I keep the disease at bay long enough? And we're sort of watching tumor biology. Is it rapidly progressing or is it not? As far as when you have miliary disease, what do we do if you're sort of at that borderline 75% tumor? What we try to do is we try to treat as much liver as we can, but keeping 2 segments untouched. So we look where the dominant disease is. So let's say you're on the left, there's a lot in the left, we'll treat the entire left, but maybe we'll keep the anterior right, we'll treat the posterior right, and then we'll let you go for a while with systemic therapy and then bring you back later, because we want to make sure that we're keeping untouched. We're not having any chance of any problem in that segment of liver. We're not doing anything. So this isn't what we used to do, but this is what we've done probably in the last 5 years, is we make sure that there's a part of your liver that we haven't touched, and it's that part that hopefully has the most amount of normal liver within it.
But anybody with tumor outside of the liver isn't a candidate,
Correct.
right? Bone metastases and so forth, they would not be eligible?
Not with the current guidelines.
Okay.
You'd have to, yeah, so if you could have lymph nodes, so you could have lymph node involvement, that would have to come out. So in general, for sort of mid-gut, base of mesentery, encasement of the base of the mesentery, retroperitoneal lymphadenopathy, it's the multivisceral transplants that we would do. The liver transplants are predominantly the metachronous and or the disease where the primary has been removed either in the panc or the small bowel, and you are doing a salvage liver transplant for a problematic area, and it is usually after you've attempted to control the disease with transplant techniques.
Okay. Question for Dr. Dillon. If your neuroendocrine tumor is because of an autoimmune problem, is the treatment the same? And in the same question, which reveals kind of what we're talking about, if gastrin is the cause, is there something to slow it down? So I think they're asking about a type 1 gastric carcinoid, which is a very specific situation.
Right. Most neuroendocrine tumors that, except for that 15% that I said were pancreatic and genetic, pretty much all the rest of the neuroendocrine tumors, we don't really know what causes them. We have an ongoing project here that I think you'll hear about this afternoon, looking for some issues in causation. However, there is one type of neuroendocrine tumor, and it's a tumor in the stomach. And it's a carcinoid tumor in the stomach that arises in people who have low or no acid production in their stomach. And these would be people who are either taking omeprazole, that type of medication that's Prilosec or Nexium at high doses for decades, or it can occur in a person who has a particular autoimmune disease. An autoimmune disease is one where the body's immune system turns in on itself and starts attacking self. So there is an autoimmune disease where the problem is that the body's immune system starts attacking the acid-producing cells in the stomach, so there's no acid in the stomach. And what happens then is that stomach cells start overproducing gastrin, which then stimulates neuroendocrine cells to grow into little polyps. Usually these polyps, these carcinoid polyps that grow, are less than a centimeter. Most often they don't metastasize, but they can metastasize. They can get out of the stomach, rarely into lymph nodes or even into liver. Did I answer the question?
I think you did. Yeah. It's a very specific situation with this autoimmune gastritis where people get these gastric carcinoids, but they're generally indolent and, treated. I mean, do we give somatostatin analogs for that, Joe?
Good question. So in some people I consider somatostatin analogs, but in most people who just have they've had an endoscopy, they've had a couple of small gastric carcinoid tumors present, I wouldn't start them on somatostatin analogs, but there are guidelines. American Gastroenterology Association guidelines suggest that these people should have people who have this autoimmune disease should have an endoscopy every 2 to 3 years. So you're going to pick up the slow-growing small polyps, and they may go for another 10 years before they have another polyp. So that would be not a great reason to put a person on a monthly medication. But there are some people who have multiple polyps, and every time the gastroenterologist goes in, there's multiple more polyps, and that would be a discussion that we might have as to whether the monthly medication, samizdatin or lanreotide, would diminish that whole cycle by decreasing the gastrin that stimulates the polyp growth.
All right, this is one for Dr. White. There are 3 questions on this, so it shows there's a lot of interest in this particular thing, and that is this new histotripsy, which is basically an ultrasound-guided way of killing tumors percutaneously without having to operate on them. And I know, are you guys a part of that trial, the 8-center trial? Well, people want to know about it. When's it going to be available? Is it going to be there's a current restriction on the trial that the tumor is less than 3 centimeters and no more than 3 of them. Can you just describe to the audience this exciting stuff?
Hope for Liver was the trial that is closed now. We closed enrollment because we completed enrollment. So histotripsy is essentially ultrasound-guided killing of tumors. So most of the ablation modalities we talk about are thermal ablation, right? So even MR-guided focused ultrasound or HIFU, which is ultrasound-guided ultrasound. So what we do is we put the ultrasound probe and we heat up the tissue. Histotripsy is different, it's cavitation. So what it does is it causes basically shaking and causes bubbling, and then it liquefies the tissue where we're focusing it. So in Hope for Liver, you had to have small tumors. The tumors had to be in a location where we could see them percutaneously. So the first generation histotripsy machine, it's crazy, we would put this like water bath on top of you. So we put 18 gallons of degassed water on top of you, and then we put an ultrasound probe, the head, on, and then we'd have to be able to see it. So the tumors had to be low in the liver and they had to be in the front. So there couldn't be a structure in between. The companies now has all this amazing software where we can sort of get between the ribs, because you have to remember your liver is way up here. And so we were only able to treat tumors that were 3 centimeters or less, and they had to be less than 13 centimeters deep. So they had to be very superficial. So that trial is over. It showed safety at 30 days. It wasn't looking at efficacy. It was looking at safety at 30 days. So we looked at patients, we treated them, and we said, okay, they had to have a 45-day break of chemotherapy, so 2 weeks ahead, 30 days, and 2 weeks after. And so what that trial showed is it's safe. We can do it. So at that time, it could be any tumor that we wanted. The beauty of histotripsy is that it doesn't cause damage to adjacent structures. It doesn't have that off-target toxicity. It's not thermal, so theoretically, we could do it next to bile ducts. Now in the trial, we couldn't. It's now on the market. It's FDA approved. There are many centers that have it. University of Michigan has it. University of Wisconsin have it. We don't have it. It cost $1.5 million to get the device in. So it's not quite at MCW yet, but many of the centers have it. The thought is that, yes, you can kill one tumor, but there's some theory, and again, proven in the animal labs, that there's an abscopal effect, which means we kill one tumor, and then we see regression of tumor from other places, because as it liquefies that area and that tumor, it has all those little things in there, the antigens that the immune system picks up, says that's not me, that's not my body, and it will start to melt away the other tumors. All theoretical, not proven at all. But so histotripsy is available in the United States at at a few centers. MD Anderson is getting it. Memorial Sloan Kettering is getting it in New York. So depending on where you are in the country, there are a couple of centers. Happy to refer you to those folks that have it. Again, MCW, it's $1.5 million, so my capital budget hasn't yet approved it. We just had a meeting about it yesterday, but coming, and the jury is out as to whether how effective it is for remote tumors, but locally it's beautiful. I mean, when you ablate with this, it's amazing. It just washes away the imaging. It just proceeds away. You don't see any imaging. You don't have the post-ablation zone that is that bad or not good. It just melts away and you can't see it anymore. So it has great applications if we can get it clinically in practice, where we don't have to look at anterior and low tumors.
Is it more applicable to, say, hepatocellular carcinoma? You know, a lot of the neuroendocrine patients have so many lesions that it might be more difficult.
Yeah, so ablation is limited to the number of tumors, so we could treat one, but if you have miliary disease, it's probably not going to be applicable for that.
Really exciting. Okay, somebody asked me a question, and that was, like, if we find a grain of rice and it doesn't show up on a scan, when do you make a call for such a surgery in a patient who has strong hormonal markers? I guess the question is that maybe you don't see anything on imaging, but you think somebody has carcinoid syndrome and maybe has a small bowel neuroendocrine tumor. And I think that's a tough call, because there are a group of patients, and Dr. Woltering referred to them as carcinoid wannabes, who have lots of diarrhea, and it's not necessarily due to carcinoid syndrome. There are a lot of people who have diarrhea for other reasons, and so that's a difficult thing to operate on for, and they may have slightly elevated serotonin levels, and it may not be carcinoid syndrome. So for me, it's pretty obvious if somebody has a CAT scan and we see an enlarged lymph node with calcifications that they are going to have a small bowel primary, so that's an easy decision. But and somebody who is absolutely negative by DOTA PET and by CT or MRI, I think it's a harder call to make if it's just a mild elevation of one of those biochemical markers. Joe, I try to send those patients to you for you to figure it out. What's your thought about that?
Yeah, it is a difficult problem, and it's very important to recognize that there are some syndromes, some other causes of symptoms that are exactly like carcinoid syndrome. So there's a condition called mast cell degranulation disorder. It's a white blood cell immunological thing that has flushing and diarrhea and indeed increased serotonin. So, and the other thing about that issue is, and it's something that Dr. White mentioned, that we usually think of carcinoid syndrome after a person has developed metastases in the liver. So that's that's fairly significantly on in the course. So it's unusual not to see something. Although there are some tumors like lung neuroendocrine tumors and some abdominal neuroendocrine tumors and ovarian neuroendocrine tumors that can cause carcinoid syndrome without anything in the liver.
Okay. Dr. Meluccio, there's a question for you, and somebody mentioned, how to manage malignant ascites. If somebody has ascites has a neuroendocrine tumor and has bad ascites, what are the things that you would employ to make that better?
I actually think that's really hard. So I don't know.
Yeah.
I don't know what you guys do. So I will say that depending on the pattern of distribution of the disease, we will sometimes explore those patients, cytoreduce them in hopes of trying to minimize the peritoneal involvement. We've started using plasma jet technology to try to see whether or not we can do something that is a little bit less aggressive than stripping the peritoneum, but it is extraordinarily difficult. It doesn't respond as well to some of the diuretic techniques that we would use for ascites from other reasons. If there is some portal hypertension component of it, we will then aggressively pursue medical management. But that I just don't believe there's a lot of data on the use of HIPEC. That's when we would end up using a chemotherapy that is instilled into the peritoneum to try to kill off some of the peritoneal surface deposits that are contributing to the ascites. But the morbidity of that, or the complication rate of that, is so high without a lot of convincing evidence that it works. So I think that's where you're going to sort of get into philosophical differences of how aggressive are you going to be in a very challenging problem where it may be a trade-off of one issue for another issue. So the short answer is that's really hard. Second is that we have probably done surgical cytoreduction in patients where we believe it's peritoneal involvement, trying to decrease or diminish the peritoneal extent of disease in hopes of better controlling it, and then using medical management.
Yeah, I'm going to ask you a question about it, Sarah, in just a second. But what Mary's talking about is that people get these implants that'll cause secretion of fluid from the abdomen. It can be very difficult to control. So that's one thing, is to remove those. But some people have it because of big nodes around the superior mesenteric vein. And I was curious whether you guys do much SMB stenting.
So it depends on why there's fluid and if it's the cell secreting or if it has to do with compression of veins, some veins somewhere. So we can reconstruct any of those veins to relieve the compression. Usually it's the main portal vein that will go in, and we'll stretch it out and put a stent in there to relieve that pressure. Now, if all of those things have been tried, surgery's been tried, it's not the portal vein narrowing, and it's not amenable to, or systemic therapy is not helping reduce the cells, there are symptomatic management things that we can do. So if we tried those things, you continue to have refractory ascites and you're blowing up and have to get drained once a week, more than once a week, you can't breathe because you can't walk, and your quality of life is diminished. We can put a drain in, it's called a Plerex catheter. So we just put a little tube that goes into your peritoneal cavity and it drains out. You can do it at home. You can drain up to a couple of liters a day safely, and so that you're able to continue to live your life and not be in the hospital all the time. The other thing we can do is a device that goes underneath your skin. It's called a Denver shunt, where it goes from your peritoneal cavity there's a little pump on the side of your body, and then it drains into your blood vessel in your heart. So there's complications with any time we do surgery. Obviously, those cells, if they are malignant, are now going to go into your bloodstream. And so this is sort of what we do at the end, just to symptomatically manage patients. But again, there are ways to manage the symptoms. And so those are just two of the options. There's many more things that we can do, but certainly if there's malignant ascites that's refractory to surgery, that's refractory to systemic therapy, symptomatically there are things that we can do to help manage the fluid so that you feel better. And it's, outside of medications, there are devices that can be implanted to help.
Okay, there are a couple questions about chemotherapy for grade 3 things, but we're going to talk about that this afternoon, so I think we'll hold over those questions. But maybe we'll just finish up with one last question. Dr. Dillon, this is for you. How many patients have no receptors on their tumor? What kind of scans do you get on those patients, and what are the therapeutic options for them?
Great question, and it's a big problem. So the vast majority of small bowel originating neuroendocrine tumors, I would say 95% of those, 95% have somatostatin receptors, and therefore the PET scan works well, and therefore PRRT works well, and somatostatin analogs work well. Pancreas is a little lower, and lung is a little lower still. So in lung, we might have 50 to 60% of tumors without somatostatin receptors. So these folks, our usual PET scan does not work. There are no parking sites to park in, and therefore they won't light up brightly on a PET scan. So we're left with CT imaging, MRI imaging to look at those. Another area where this becomes a problem is that as tumors go on, sometimes they become higher grade, or they're higher grade from the start, and they lose those receptors, somatostatin receptors. So again, we don't those tumors will not show up on PET scans. They won't be amenable to PRRT. They won't be amenable to somatostatin analogs. And so often in those folks, especially with liver tumor, rather than since PRRT is not an option, we really consider the Y90 radioembolization therapies in those folks for the liver component of their tumor. But it's also a reason to do more surgery to deal with tumors and to deal with tumors and resect tumors, if resectable, that don't have those receptors. And finally, receptors or no receptors doesn't make a difference to whether you're on Afinitor or some of the medications that Dr. Chandrasekharan, some of the chemotherapeutic and other medications that you will hear about this afternoon.
All right.
Yeah, if I could add one thing to that, I think I'm curious what you guys do, is that I think when we either have what we believe is mixed grade, meaning some things are looking more avid and some things aren't, we have a low threshold for getting the FDG, the other type of PET scan, to better understand whether or not there are features of it that would suggest a higher grade tumor despite what it is that we're getting from the pathology. We also have a very low threshold for sending next generation sequencing. That's when we test the genetic profile of the tumor itself and see whether or not there are identifiable mutations whereby we have targets, even if it's a drug that they use in breast cancer. We're sort of allowed those under a humanitarian device exemption in rare cancer diagnoses, as long as we can make a justification for it. And then Dr. White may be able to comment on the fact that we also have a very low threshold. I'm probably less likely to jump into surgery on a mixed grade or a higher grade histopathology unless it's with palliative intent. But that liver-directed therapies are less dependent on grade for their response. It's the durability It's how long the response will last because of the mechanisms that the cancer has of growing at a quicker rate. So you have a very low threshold, and I totally agree with Dylan. I'm less likely to use Y90 in lower grade tumors, more likely to use Y90 when I don't think PRRT is going to be an option. And she can comment on sort of the nuances of the choice of platform, because I think that the Y90 probably is got some benefits in higher grade tumors.
Yeah, so high-grade tumors are patients that are really, really catabolic. That's our first choice is Y90. And then those lower-grade patients, we're going to do a chemoembolization to start algorithm, or bland.
All right, and I'm sure Dr. Chandrasekaran will talk about this more, because we would often have a low threshold for biopsy to see if it's a grade 3 and then maybe chemotherapy, but stay tuned. All right, thank you everybody, thank you panelists, and thank you everybody for your attention. Bye.